I'm Dr. Vizniak. Just a little background on myself before we actually get into our lecture about glenoid labral tears in the shoulder. I am the chair of physical medicine at the Boucher Institute of Naturopathic Medicine. I'm also the director of Professional Health Systems, which is a company I started. And we write and sell books on these very topics, basically anatomy, orthopedic testing, physical assessment, in about 17 countries around the world right now. And I'm also giving this lecture for Bowen College just around the glenoid labral tears, an often misdiagnosed condition that's overlooked for many years for a lot of patients. So the first thing that I want to do is, all of you have done your pre-reading ahead of time, I just want to get a gauge for what are the key things that you should know about a glenoid labral tear when you're talking about history and signs and symptoms. Deep aching pain somewhere inside the joint. All right, what else?
Not getting better despite seeing several practitioners.
So yeah, one of the key things, it's not getting better despite seeing several practitioners. What else? Sorry? Yeah, so history of overuse, usually overhead, repetitive type activities. All right, any orthopedic tests that you can think of that we know for this condition? Okay, so we got Clunk test, Crank test, O'Brien's test. Those tests show moderate to good statistical reliability, but there's a new test that I want to show you guys called the Biceps load test. Now the Biceps load test basically works by applying a tension force to the glenoid labrum from biceps long head in the same position as the Clunk and Crank. A lot of orthopedic tests, and even board exam proctors aren't aware of this test. It's just recently come out in the last 7 or 8 years and is showing a lot of good data. So if we could, I'll get a volunteer up here for us really quick. Miss Novia, if you would be so kind as to come up here. All right. And of course, remembering your basic anatomy back to the glenoid labrum attachment points, biceps long head attaching there, running all the way down the arm. What's a basic test that you could do, even as a muscle test, for a labral tear? You could do active range of motion, resisted range of motion. What type of resisted range of motion specifically? Yeah. This is a shoulder pathology, but a lot of doctors forget and practitioners forget that you can test this by doing an elbow resisted range of motion because of the biceps attachment all the way up here. So if we look at the biceps load test 2, the patient is basically put into this position right here, which is very similar to our Clunk and Crank test. But what you wind up doing is, in this position, you're going to hold your arm there for me, Novia, and what I'm going to do is I'm going to go ahead and just pull on the arm like this, okay? So go ahead and just resist that. And this pulling on the arm from that position takes the biceps brachii long head and tractions on the glenoid labrum and allows for, hopefully, well, not for the patient, but hopefully for your diagnosis, an increase in pain in the shoulder and a way for you to actually isolate this pathology. Remembering, of course, that this is often misdiagnosed as a supraspinatus tear or subacromial bursitis or a multitude of other shoulder pathologies. If you catch this early, you can prevent the early onset of osteoarthritis, progression of the labral tear, and many other pathologies of the shoulder. Thank you very much, and that'll be it for this discussion.